Respiratory. In your assessment textbook, you're going to find these terms and the definitions, but let's go over them now. It's important to be familiar with the terminology as we discuss the respiratory system. When we're talking dyspnea, this means difficulty breathing. Apnea is the absence of breathing. Anytime we put an A in front of a suffix or the root of a word, then that means we have absence of. Potentially the apnea will be periodic, so it may not be a complete total respiratory arrest where we have no breathing whatsoever, but it may just be intermittent. Tachypnea, the tachy means increased rate. Bradyapnea, the brady meaning decreased rate. Orthopnea is having dyspnea when we lay down. Kussmaul's respirations, this is the rapid, deep breathing. Cheyne-Stokes, we have faster and deeper breathing, and then it's going to slow down and have periods of apnea. So basically we have some dyspnea with short periods of apnea. Biot's respirations, we have rapid, deep breaths with pauses. I want you to look at this picture. It gives you a picture on the left of a man with a normal diameter of the chest, and on the right we have what we call the barrel chest. The barrel chest is important. It lets us know that we have a client who has chronic respiratory issues such as emphysema. This is due to the fact that they are no longer able to exhale all of the carbon dioxide in their system. So their body retains it and the lungs just get bigger and bigger and bigger. So over a long period of time, a client with a chronic respiratory disease such as emphysema will develop the barrel chest. This shows you the different areas, different ways to determine where we should be placing our stethoscope when we are doing our auscultation. So when we're looking at the front of the chest, we have the anterior reference lines, and we're going by the clavicle and the sternum. So the sternum being the middle of the chest, and then we look at the right midclavicular and the left midclavicular. But when we flip the client around to the back and we're looking at the posterior part, we're looking at the spine as being the center, so the vertebral line, and then we're looking at the scapula. So mid-scapular is going to be the right scapular line, and the left side, it would be the left scapular line. This is a picture that just demonstrates the lobe locations in the chest. We know on the right side we have 3 lobes, and on the left side we have 2 lobes. We're looking at basically the right upper, middle, and lower, and then the left upper and lower. When you turn the client around and you're looking at the posterior side, there's really only 4 areas of the lung that we're going to auscultate. However, we still will auscultate the same way, and I'll discuss that here momentarily. But this picture just shows you where the different lobes are located. And then the lateral shows you the sides. So when we are actually doing our auscultation, we're going to go 6 points. 6 points on the front and 6 points on the back. And this is going to cover all of the different lobes of the lungs and the different areas of these lobes. So always go at least 6, front and back. We go upper, the picture shows you the right upper, then goes to the left upper, then you go down to the right mid, the left mid. So we go from side to side, down, side to side, down, side to side. We're doing that so we are assessing bilaterally, making sure that there are no differences from side to side. Okay, so moving on, then we look at our respiratory interview. What are some of the questions that we should be asking our client when we are doing our interview? We suspect they may have a respiratory illness. Do you have shortness of air? If they do they have shortness of air with activity, or is it all the time? Or is there anything in particular that will cause it? Does it happen at a specific period of the day? Do they have orthopnea? So do they get short of air when they lay down? Or do you have to sleep in a sitting position, such as in a recliner? Do you have a cough? And if they have a cough, how often is that cough? Is it a wet cough where there's mucus being moved around, or is it a dry cough? Has the cough changed recently? Have they taken any medications for it? If so, has it helped? Are they coughing anything up? So is there any sputum? And if there is sputum, how much is there? What color is it? Is it really thin or is it really thick? Is it dry and sticky or is it pretty wet? And do they have any pain with breathing? So as we're doing our physical assessment, there's several things that we need to be looking at to help us determine if there's issues going on with the respiratory system. We first look at their level of consciousness, because a change in the level of consciousness might be the first indication that the client is not getting enough oxygen. They're experiencing hypoxia. We inspect the client's chest anteriorly, posteriorly, and from the lateral side. We're looking at the shape. We're also looking at symmetry. So is that shape the normal shape? Do they have that barrel chest? Do they have symmetrical chest wall movement on both sides? What is their respiratory rate and rhythm? Then we're going to auscultate. We use the diaphragm of the stethoscope and we listen over the anterior chest and the posterior chest. Make sure that you warm that stethoscope between your hands before you put it on someone's bare skin. Nothing quite like cold metal being placed on the skin. Then we instruct this client to inhale and exhale through their mouth. This allows us to hear those breath sounds just a little better. And what we're listening for are some of those adventitious sounds. In other words, abnormal sounds. Normally, we should just hear air moving in and air moving out with each inhalation and exhalation. We should not be hearing those adventitious sounds such as crackles or rhonchi or wheezes, etc. Make sure that you are counting respirations for 30 seconds and multiplying it by 2, and doing this without the client being aware of what you're doing. Again, the normal respiratory rate for a healthy adult is 12 to 20 breaths per minute. If we have a really ill client or a client that has irregular respirations, Make sure that you count for a full minute. Increased levels of carbon dioxide or lower levels of oxygen in the blood can cause an increase in that respiratory rate. And a change in the respiratory rate can indicate a change in the client's condition. But remember to always look at the other vital signs and assessment data before you begin coming to some conclusions. Many of the factors that affect the pulse rate will also affect the respiratory rate because, again, those heart and lungs are closely connected in providing oxygen to sustain life. The breathing rate, if we have an elevated temperature, is going to increase about 4 breaths for each 1 degree Fahrenheit elevation or 1/2 degree Celsius elevation. If the client is breathing too fast, they're not getting enough oxygen to the tissues, or maybe they have a higher oxygen demand. This could be caused from exertion, respiratory infection, chronic respiratory disease, airway obstruction, a collapse of the lung, an inability to fully expand the lungs. For example, someone who's obese or someone who has overeaten and overfilled their stomach, or cardiac problems. If they're breathing too slow, this is often due to an airway obstruction, respiratory acidosis, sedation, drug overdose, or cardiac arrest. We need to assess the oxygen saturation. We like for it to be greater than 94%. However, if it's above 90, we definitely look at the rest of the picture to determine if it would be acceptable or not. Again, we prefer it to be over 94%. We consider that to be normal. However, in some cases, we will be okay with a slightly lower reading between 90 and 93%. The oxygen saturation, once again, measures oxygen by the saturation of the blood by determining the percentage of hemoglobin that is bound with oxygen. And we determine this by attaching a sensor or a probe to an area of the client's body, and then we shine infrared and red light to reach the capillary bed. Oxygen saturation, if you recall, can be affected by the temperature of the fingers, some nail polishes, movement of the finger, and an irregular heartbeat. Different types of probes. Once again, we can put probes on the fingers or toes. Those are the most common, but there are some adhesive probes out there, some sensors that can be applied to the nose or the forehead, or in the case of an infant, maybe we attach it to a foot, or we can attach an adhesive one to a finger. We can also get a special clip to attach to an earlobe. We look at the respiratory pattern. Is it regular? Do we see some flaring of the nostrils? If we do, then that means that that nose is flaring to hopefully draw more air in as they're breathing. Do we see that pursed lip breathing? The pursed lip breathing is like making a kissy face or a fishy face as they're blowing air out. This helps in the elimination of carbon dioxide. It slows the expiration down, again, to help get rid of more carbon dioxide. Do we see them using the accessory muscles, so the stomach muscles or the muscles in between the ribs, to breathe? If we do, then that means maybe they're having some problems with their respiratory system. We also look at skin color. In the darker skinned people, we're going to look at mucous membranes. We can also look at the nail beds because most of those should be pink, even in the dark skinned person. In the lighter skinned person, it's a little bit easier to determine if they have a pink color to their skin. What is their position? Are they able to lay down flat? If they are, then they're probably not having respiratory problems. Do they have to sit up in order to breathe? Are they leaning forward to breathe? And then we look at finger clubbing. And there's a picture on this slide that shows you how to put those fingernails together and what it looks like if we have clubbing versus a normal configuration. Finger clubbing, if we see this, it shows chronic hypoxia. So we often see this in clients that have significant respiratory disease or significant cardiac disease that's been going on for a long period of time. Okay, so we've done our assessment. We've looked at the client. Now, what do we do? First of all, we're going to consider putting oxygen on a client. We do not need a doctor's order to put oxygen on a client. However, we will obtain an order after we have cared for the client. Elevate the head of the bed. Most people who have respiratory issues are unable to breathe when they're lying down. They need to be in an elevated position. We may administer medications orally, IV. We may give it through an inhaler or a nebulizer. Chest physiotherapy. This is where we do some vibration or percussion on the chest to help loosen mucus. And then we do some postural drainage by turning them from one side to the other to help move that mucus around so they're able to cough and expectorate it. Reassess. Always reassess, especially after you've done any type of intervention. Some of the diagnostics that we may do would be the oxygen saturation, doing that simple respiratory rate and rhythm, a chest x-ray, or other imaging such as a CT scan or MRI. We can also do a pulmonary function test where we determine the capacity of the lung and how well they're able to breathe. And we can do a bronchoscopy where we put the client to sleep and then we go down into the lungs with a scope and we look for obstructions. We can do biopsies. We can do washings, take samples of mucus and or tissue.